children, but some seizures mimic seizures equal to the seizure. Is there any difference? You please explain. Because still I am some doubt whether this seizure mimics equal to seizures. Okay? Thank you. Carry on.
Good evening. Thanks to the organizing committee for this opportunity. So epilepsy affects 0.5 to 1% of all children, and it is a common neurological condition, and the highest prevalence is in infancy. When a child or an infant presents to us with a paroxysmal event, the first step would be to differentiate whether it is a seizure or a seizure mimic, whether it is not a seizure. So sometimes seizure mimics can confuse us so much that the child undergoes a lot of unnecessary investigations and treatment for epilepsy. The rate of misdiagnosis for seizure mimics as epilepsy reaches up to 39%. If there is an accurate diagnosis, it can prevent a lot of unnecessary investigations and treatment. But sometimes it is hard not to investigate because the parents are so stressed out that they would prefer an investigation being done, say an EEG, and it being normal rather than it not being investigated at all. But even after investigation, if we tell the parent that it is not an epilepsy, that it's a paroxysmal non-epileptic event, it just relieves them of a lot of stress. In older age group, video EEG can help in differentiating functional seizures from seizures. So usually there are certain criteria, certain red flags that show that it is a seizure mimic. That is, it will be triggered by a particular event, a location, or an emotion. The event can be of long duration, lasting up to 10 to 20 minutes. They are so long in duration, but yet there is no post-ictal period, and then they are suppressible. So these are certain criteria for seizure mimics. Whereas seizures, they occur out of deep sleep. There will be a loss of consciousness. And after the event, after the seizure, there is usually a period of fatigue, which can last from minutes to hours. And the movements are not suppressible. There might be a past medical history of autism, developmental regression, or neurological injury that increases the risk for seizures. But just with one red flag or with one green flag, we can't say that if there is one green flag, we can't say that it's a seizure mimic. So we need them together, a few red flags or green flags together to differentiate between seizures and seizure mimics. There are different paroxysmal events according to the age of the child. In the newborn period, we have jitteriness and benign sleep myoclonus, rarer conditions like hyperexplexia. As the child grows, they might develop benign torticollis of infancy, infantile masturbation. They can, by around 6 months of age, they can develop breath-holding spells. After 1 year of age, we have benign paroxysmal vertigo, stereotypies. In older children, around 4 to 5 years of age, there's cyclical vomiting, tics. And in the adolescents, there are paroxysmal non-epileptic seizures, and there is hemiplegic migraine also. So this is a well child. We see that he has bilateral movements. He's in deep sleep. The movements do not involve his face. But otherwise, his birth and development so far up to 2 weeks was normal. This is a child with meningitis who has unilateral jerking of the right upper limb. So very often we have this, parents coming to us with children having paroxysmal events that occur during sleep. If the child is normal with no history of fever, no history of infection, or no perinatal complications, if these movements occur only during sleep, they may be bilateral or unilateral, usually do not involve the face. It is a benign sleep myoclonus. If there is, parents are quite concerned, we can do an EEG to show that it is normal. Antiepileptics are not required for this condition. It is benign and it resolves by 3 to 6 months. This child has quite a lot of comorbidities, but we see these high frequency, low amplitude movements which are suppressible. As soon as we hold the hand, it stops. So this is jitteriness, where it is typically suppressible. And it is not associated with autonomic symptoms or abnormal eye movements. It can be exacerbated by stress, like crying, or sudden movements. If it is severe, we have to work up for secondary causes of jitteriness like hypoglycemia, hypocalcemia. But generally it's a benign condition which improves by 2 weeks. Rarely it can last up to 1 year of age. These two are quite common, which we see in day-to-day practice. This is quite rare. This is a child having exaggerated startle followed by a period of stiffness. This is typical of hyperekplexia, which is exaggerated startle. The startle can occur in response to auditory, visual or tactile stimulation. It's otherwise a healthy infant. It is a genetic disorder as a result of mutation in the glycine receptor. We might need an EEG to differentiate it from more malignant conditions like myoclonic or startle epilepsy. We will also have to rule out other conditions of exaggerated startle like disorders of the brainstem, anoxic injury, tetanus, and other metabolic conditions like Tay-Sachs disease. For this exaggerated startle, clonazepam is sufficient for treatment. As the child grows older, they will grow out of the startle reflex. Breath holding spells again are very common. The child holds the breath in expiration. After this period of breath holding, they can even lose consciousness and have a seizure also. Even if they have this seizure, breath holding spell triggering a seizure does not need to be treated with anti-epileptic drugs. Even if the child doesn't have iron deficiency, current research suggests that these children require iron supplementation to reduce the severity and the frequency of breath holding spells. Some of these children, they go on to they develop severe bradycardia, so drugs like atropine and glycopyrrolate can be used to prevent severe spells with loss of consciousness and seizures. Newer drugs like pyracetam and melatonin can be used. Pyracetam is at a dose of 50 mg per kg and melatonin at 0.08 mg per kg once a day. But sir said that melatonin shouldn't be used in, but yeah, so this is, there are few studies coming up. There are no RCTs as of yet to the use of melatonin. Most importantly, reassurance to the family and education is sufficient that even if it is a seizure occurring as a result of the breath holding spell, techniques to distract the child and some supplemental medication like pyracetam can reduce the severity and nothing further is needed. So this is a toddler. She has torsional movements of the body. There is some rocking movements also. It's very typical of infantile masturbation or self-gratification disorder. It is a part of normal development. It is a normal healthy behavior. But it is better to distract the child when they have such episodes. They can have autonomic changes like flushing or sweating, but there is never loss of consciousness. Some episodes can last as long as 2 hours. Once we make this diagnosis, no further neurological workup is needed. However, in older children, nearing their teens and adolescence, sexual abuse should be considered. Now going into pediatric migraine variants, we know how common migraine is in the general population. Not all children with family history of migraine develop headaches in childhood. They have other migraine variants like infantile colic, alternating hemiplegia of childhood, benign paroxysmal torticollis, benign paroxysmal vertigo, cyclic vomiting syndrome, abdominal migraine, and vestibular migraine. Of these, BPT, benign paroxysmal torticollis, benign paroxysmal vertigo, and cyclic vomiting syndrome, most likely mistaken to be seizures because they are paroxysmal events. They are normal between the attacks. These children have a family history of migraine and they later on develop classical types of migraine. So benign paroxysmal torticollis is a head tilt in a normal child. It may be associated with vomiting. We have to differentiate it from gastroesophageal reflex and idiopathic torsional dystonia or even complex partial seizures. This is something which needs workup because a child with a head tilt might be harboring a posterior fossa tumor. So imaging is required and EEG also has to be done. If everything is normal, then parents just need reassurance. But it has been studied that children with BPT, benign paroxysmal torticollis, may go on to develop benign paroxysmal vertigo and later on cyclical vomiting syndrome, and as they grow older, migraine. That was a video of a child with benign paroxysmal torticollis. Doesn't seem to play. So, benign torticollis, it occurs in a younger age group, 1 year and less, or maybe up to 18 months. But this benign paroxysmal vertigo is in slightly older children, around 2 years of age. They have severe attack of vertigo. They are not able to describe it, so they are usually very terrified. They have associated vomiting and again no loss of consciousness, just paroxysmal attacks of vertigo, which can last for from 5 minutes to several hours. They are completely normal in between the attacks, and anything that triggers a migraine like lack of sleep, not eating at the right time, stressful factors, traveling, bright light can trigger these attacks. We will have to rule out intracranial pathologies. And once they are ruled out, drugs used in the prophylaxis of migraine like cyproheptadine and propranolol can be used. Cyclical vomiting syndrome is in an older age group, usually after 5 years of age. Recurrent attacks of abdominal pain, headache and vomiting. So the vomiting is most severe in the first 1 hour and then it subsides. These can also be prevented by drugs used in the prophylaxis of migraine. So when we notice that the child is having cyclical vomiting syndrome, when the attack starts, like we treat migraine, we can use abortive therapy using triptans, supportive care to prevent dehydration, and prophylactic agents like cyproheptadine and propranolol, or even amitriptyline can be used. We see here a 4-year-old child with recurrent episodes of eye blinking. These can be mistaken to be seizures, mistaken to be absence with eyelid myoclonus. But these are tics. Tics are repetitive, rapid movements. They can last several seconds. They are non-rhythmic in nature. There are 2 types of tics, motor tics and vocal tics. Motor tics can be simple, like this, an eye blinking, or there may be shrugging of shoulders. They may be even complex, but they are usually non-purposeful. The child may repeatedly bend down, pick up something and get back up. They are non-purposeful movements. Vocal tics can also be simple or complex. Simple tic is just a sound like a bark or throat clearing. Or complex tics, they can repeat certain sentences or phrases over and over again. They are associated with a premonitory urge. It is triggered by stress, excitement, fatigue, fever or infection. So if there are 2 motor tics and 1 vocal tic for more than 1 year, we suspect the child of having Tourette's syndrome, which can be associated with other neuropsychological comorbidities. These movements are not harmful at all. The best way to treat tics is to start early and that is with behavior therapy using positive reinforcement techniques. If they are not responsive to positive reinforcement, we can try tier 1 medications like clonidine, guanfacine or topiramate. Still not responsive, antipsychotics, and dopamine depleting agents like tetrabenazine and valtetrabenazine can be used. So, stereotypies and tics are different. Tics are in older children around 5 to 7 years of age. They usually involve the eyes, the face, the heads and shoulders. They are very brief. Whereas stereotypies are rhythmic. We saw that tics were non-rhythmic. Stereotypies are rhythmic and prolonged in duration. They have no premonitory urge. The movements are consistent and fixed in their pattern. For example, a child with autism having flapping movements of the arms, recurrent nail biting, lip smacking movements are all stereotypies. Sometimes it's not the brain at all. It's the heart which causes the problem and makes the brain look funny. Syncope is very often misdiagnosed as epilepsy. The prevalence of syncope is as high as 37%, whereas that of epilepsy is just 0.75%. There is a fall in cerebral perfusion that leads to transient loss of consciousness with loss of postural tone. Reflex syncope is more common, but we have to rule out cardiac syncope. So history taking is very important when a child presents to us with loss of consciousness. There will be a prodrome. There is lightheadedness, there is blackening of vision or muffling of hearing and nausea. Then there is the index event, which is the loss of consciousness with cold, clammy extremities. Very rarely when the child falls down, they may have 1 or 2 convulsive jerks and incontinence if the bladder is full. But tongue bites are very uncommon. Recovery is rapid, that is, they are oriented immediately after they regain consciousness, but they may remain tired for hours. So recently I had a call from for a child. She was 5 years old and she kept telling her, she was being loaded repeatedly with anti-epileptic drugs. She will tell her mother that she's feeling lightheaded and then just drop down. There were no convulsive jerks, there was no episodes of incontinence or lateral tongue bite at any time. But this kept happening repeatedly. So by history, I felt that since she has a prodrome and then an index event, it's more likely to be a syncope rather than a seizure. So we stopped loading her with anti-epileptics. We had a detailed cardiac evaluation with a 12-lead ECG, and the cardiologist felt that there is no cardiac cause for the syncope. Then again, on examining the child, suggestibility was present, which pointed out to a functional event in a 5-year-old child. So history taking can help differentiate a syncope from an epilepsy even without many investigations. So usually a syncope occurs in an upright position. There is a prodrome of lightheadedness and the onset is gradual. It can last for a few seconds, maybe up to 30 seconds. Convulsive jerks can occur in a syncope also. Incontinence is uncommon, but if the bladder is full when there is loss of consciousness, there might be incontinence. But tongue bites are very atypical for a syncope. Even they regain consciousness immediately, but they may be fatigued afterwards. Whereas a seizure, it is sudden. Tongue bite and incontinence is quite common in a seizure, and postictal confusion is present. In a cardiac syncope, which we have to work up for in a child presenting with recurrent episodes of syncope, there is no postictal confusion and there is no fatigue also. So syncope in a child under 6 should raise suspicion for a seizure, breath-holding spell or cardiac arrhythmias. Non-epileptic seizures are very common especially if they are asynchronous, asymmetric shaking or hip thrusting. The eyes may be tightly closed. They might try to open their eyes and make eye contact with someone. There is a gradual crescendo, and these events last for a long period, say 15 to 20 minutes. And when they recover from these episodes, there is no postictal confusion. A video EEG is very effective in differentiating non-epileptic seizures from epileptic seizures, and this will help us in weaning the child of any anti-seizure medication. This will be labeled as a functional neurological disorder. This was a video EEG in a girl who had recurrent unilateral jerking of the right upper limb. The video of the girl I couldn't upload because of some technical issues, but this is the EEG of the child, where so the EEG of the child did not show any interictal discharges. She responded to behavior therapy alone. One red flag we saw when we looked into the paroxysmal events was that events that occur out of sleep can be labeled as seizures. But not all events occurring in sleep are seizures. Frontal lobe epilepsy and benign epilepsy syndromes like self-limited epilepsy with centrotemporal spikes can occur in sleep. Structural epilepsies like those with focal cortical dysplasias occur out of sleep. So also parasomnias. The hypnic jerks can mimic myoclonic jerks. Sleep enuresis can be mistaken for incontinence. Sleep terrors, sleepwalking, and sleep talking can be difficult to differentiate from frontal lobe seizures. And periodic limb movements may be present, which also may be mistaken as seizures. For all these, an overnight EEG recording will help differentiate from an epilepsy. So in a sleep terror, the child wakes up out of deep sleep. There is a sudden arousal. The child sits up, is extremely agitated, screams, can have some motor movements, and attempts to wake up the child just increases the confusion. There are a lot of non-REM sleep associated parasomnias like confusional arousals. The child may just wake up and stare and then go back to sleep. Wake up, stare and start walking. Or they can wake up with intense autonomic discharges. They are extremely distressed and then go back to sleep. So these events, we have to have a knowledge of these events to prevent unnecessary use of anti-epileptic medication. So just correcting sleep, improving the sleep hygiene is sufficient in treating these children. These were my references. Thank you for the opportunity.
Very useful talk, I have some doubts. In newborn period, there is previously told about physiological